Cheryl, thanks for coming. How are you feeling? Oh, hang on, you're muted.
I feel very guilty because I haven't been studying very much.
I don't know how you can study for the oral, and honestly, I think you almost need those couple of weeks for everything you learn to like settle into place in your brain. Do you
Yeah.
feel a bit more settled now? Like you don't have that buzz?
Mm.
Yeah, good. That's the idea.
I feel like I've forgotten loads though that I learned for the
Yeah, you will have, but you had excess knowledge. So you got some to lose.
You do, Helen.
Yeah, that's true. So to do a slideshow to do the exam formally, so I'm gonna try and be a professional examiner and not go yes, yes. But what we'll do is I think there's 5 questions, but there's different parts. So you can either do maybe it might be best if you do a full question each and just alternate, or if Alana's on, if she wants to participate as well, she's welcome to, but no pressure. And anyone else that joins, we can just kind of take turns rather than doing parts of questions each. There's a couple of questions in there, Helen, that I know that I've examined you on before. One question, so I'm going to give that one to Cheryl.
Sure. Okay. I am now a professional examiner. Can you tell me though, before I turn professional, can you see my presenter view or just the slide? So now we can see presenter view, but before we could just see the slide.
Okay. It's not very good for presenter view, is it? Okay. Cool. So welcome to the practice oral exam for memberships 2025.
Anna, now we can see the next slide. Oh yeah, that's
Yeah.
right,
Yeah, I'll go back. Yeah. Thanks. It's a giveaway.
You've got
don't forget the points are awarded for the information. Like if you knew what the test result was, then it would actually probably lose you marks in the question before. So if you do that like anchoring bias and you go, oh well, it's almost certainly this, and then you lose like the breadth of your differential list because you're focused in a rabbit hole, definitely will work against you. So the way that the exam is formatted is we're starting question 1 now. You are presented with an 8-year-old male neutered golden retriever, referred for lethargy, intermittent lameness, and increased drinking over the last 3 years. 3 weeks, sorry. I wrote this. On physical exam, the dog has pale mucous membranes, a grade 2 out of 6 systolic heart murmur, a mild lymphadenopathy, and pain on palpation of the lumbar spine. So at this point, they'd probably say, take a minute to make some notes, or they'd wait for you to stop making notes. So in my experience, all examiners will do something like this and give you that information to refer back to. So I've just, well, did that just skip? Yeah. So you've got all the information there, but in theory, it might be worth just jotting down as you go, 8-year-old, no new to golden, pale, grade 2 murmur. On physical examination, the dog has a grade 2 heart murmur. Some blood tests were performed, and the abnormal results are shown in the panel here. Take some time to review these results. When you're ready. First question, 1A, is provide a list of 3 differential diagnoses for this combination of findings.
I'm happy to go if that's all right, Sherilyn. Sure. My first differential diagnosis would be multiple myeloma, given the elevated globulins and calcium. A second, I don't need to justify, do I? No. A second would be an acute kidney injury. And third, I was kind of thinking like an IMPA or SRR, like an immune-mediated systemic disease. I'm going to say IMPA.
Good. How would you assess the murmur in this patient?
So I would assess the murmur further. Does that mean physically? So as in
Sorry, no, like what do you think might be contributing to the murmur?
Oh, so I'd have a look in the patient's history to see if it had ever had a murmur noted before.
But said new murmur, yeah.
If that, if the murmur and the anemia are new at onset, I would consider it's quite a soft low grade. So I'd consider that it could be a murmur secondary to change in viscosity due to the anemia.
Excellent, good. I'm going to proceed to the next slide. Question 1C, what additional testing would you like to perform in this patient to clarify the differential diagnosis still on your list?
Okay, so I would perform a CBC. That might be a manual PCV. We'd need a hematology to further assess the anemia, whether there's reticulocytes, whether it's regenerative or not, hemoglobin concentration to further assess that, and a blood smear. I would perform a dipstick and sediment exam urinalysis if that hasn't been done already. I would perform an ionized calcium because there's a total calcium on there, just to make sure that's not a spurious finding, and further assess if the ionized calcium's high. I would assess electrolytes. They may have already been done and just be normal. That's why they're not there.
Full biochemical hematology urinalysis has been performed, and these are just the notable findings.
And I guess you could also consider a basal cortisol for that patient. I didn't mention hypoadrenocorticism, but I think that would be fair. After that minimum database, I would take survey radiographs. So you'd mentioned the dog has got pain on lumbar spinal palpation. With that hyperglobulinemia and those lab findings, with multiple myeloma being quite high on the differential list, we'd want to assess the long bones for evidence of lytic lesions or other causes of pain. So I'd take long bone and spinal radiographs. If they were quite suggestive of lytic lesions supported with multiple myeloma, we could do a bone marrow biopsy for plasma cells. If they weren't supportive of that, it might change our direction. So we might, for example, take thoracic radiographs or do an abdominal ultrasound looking for other sources of that hypercalcemia, other causes of anemia. I don't know if this is too many things to say. We could perform an echocardiogram to further assess that murmur to make sure that's he's not got even though we've said it could be due to the anemia, if he's also got cardiac disease, that might significantly change the treatment protocol that we recommend for him. So more for just as ruling out that cardiac disease isn't a significant comorbidity would be reasonable. And protein electrophoresis on the globulins, particularly if the radiographs were suggestive of multiple myeloma. for a monocolony of globulins that could suggest a neoplastic process.
Good.
And that's it, I think.
Good. Excellent. So I'm gonna do feedback at the end of the full question, if that's all right. So a lot of tests were performed, and protein electrophoresis revealed a monoclonal gammopathy, which is suggestive of one antibody being replicated over and over again. Radiographic report from a radiologist of the spinal radiographs revealed multifocal lytic lesions evident throughout long bones and vertebral bodies. Question 1D, provide the most likely diagnosis for this patient on the basis of these findings.
Multiple myeloma, so neoplastic proliferation of antibodies.
Great. Question 1E, list any further testing you would like to perform.
I think that's really suggestive of a neoplastic process, but you could do a bone marrow biopsy for neoplastic plasma cells if you wanted confirmation.
Great, excellent. Discuss treatment options for this patient.
So I think you'd have a range. Firstly, chemotherapy options, so chemo with prednisolone. You can use various chemotherapy protocols like melphalan, and you can cycle through almost like a CHOP protocol with cyclophosphamide, doxo, and pred. You can, if the patient is really, we mentioned that he's painful, we'd also, in combination with that, use analgesia and bisphosphonates like pamidronate, which can reduce the osteoclast activity, stabilize bones, and potentially have an analgesic effect and prevent pathological fractures of the affected bones. You can also do that in combination. I think you can use radiation therapy. I don't know if that changes survival times, but can have an analgesic effect. And then other supportive therapies. So, for example, I mentioned analgesia, but things like meropitant, appetite stimulation, if you need to use those alongside chemotherapy.
Excuse me. Ooh.
And I think that's it.
Yes. Oh. Excellent. So that was probably like a 96% answer. The one thing, and in hindsight, what I probably should have done in the way I worded this question is got you to do a problem list. And
Yeah,
would usually do that because it just means that you've then taken the time to write down exactly what you're assessing. And in your list of 3 differential diagnoses, none are wrong. And when you get a question like that, what they're trying to tease out is like there are multiple different pathologies that might be going on here. Are you capable of looking at a big picture and then prioritizing your testing because you're more suspicious of one process over another, or knowing what happens more commonly than others? So obviously the kind of your initial assessment, it's multiple myeloma, is completely right. I don't think your other differentials would have been my 2 and 3 differentials. So looking at the whole picture of a little bit of anemia, a hyperglobulinemia, and hypercalcemia, and then I probably would say that mild renal change is maybe secondary to the hypercalcemia.
Yeah.
Or dehydration. Oh, well, it's not dehydration. We've got some renal compromise there. So given that those 3 are kind of the most important things, and we think the murmur is maybe PCV related, I would probably put lymphoma on there as well.
Yep.
And then the globulin's like quite a specific thing. Like it doesn't really happen with like very many differentials. So I kind of put a lot of weight on that, but I'll probably put chronic inflammatory infectious disease on there. And
Okay.
with with this spectrum of findings, maybe endocarditis.
Oh, yeah. Great one.
But yeah, but like I would probably like chronic infectious or inflammatory disease would be kind of anything under that umbrella should probably be on the list when you got a globulin like that.
Mhm.
Other than that, you had more than I had on my answer key. So that was the only part of the question that I thought there was any feedback to give, basically.
Lymphoma is a good one, especially with the lymphadenopathy.
Yeah, so hyperglobulinemia, like that's always, that makes me go, okay, that's my number one thing I want to be assessing, because there's actually not very many things that cause that, whereas so many things cause anemia, so many things cause mild renal value or mild renal compromise, so many things cause mild total hypercalcemia, but the globulins, I'm like, let's focus on that.
Yeah. That makes sense.
Okay, question 2. Cheryl, oh, Mitch, do you want to play?
I got a meeting in about 10 minutes, so I won't be able to stay for the whole thing as much as I'd love to.
You should probably do question 2 then.
Yeah, I can have a
Okay, excellent. So I'm gonna learn from my mistakes and say question A is always make a problem list for this patient.
Yeah.
Okay. So I'll just gonna let you read it rather than read while you're trying to read.
That's right. Let me just get a bit of pen and paper.
Anna, just while we think, can I ask, if we take too long, do the examiners have a set time, like 15 minutes per case or something? Will they gently move us along, or it's fine? They won't. Okay, we don't have to worry.
But you've got enough time that like you would have to be waffling or like in a flat spin panic and not talking at all for them to like move you along. Like you can waffle quite a bit.
Okay, so taking like a good minute at the start to write a problem list is more than enough time.
Yeah, and it's actually going to set you up better.
Yeah, it's helpful. I agree. Thank you.
Yeah, if you sense them moving you along, it means you've either got everything on their answer list, on their answer key, or you're way off topic.
Okay.
Don't want you to waste time going any further, and they want to give you a bit more information to get you back on track.
Okay, thank you. Sorry, Mitch.
Do we assume a hematology has been done in this, Anna?
Yeah. Sorry, yeah. So full biochemistry, hematology, urinalysis, and USG has been performed, and only the relevant findings are shown on the screen here.
So urine dipstick's been done as well.
Yes, yeah.
So with these laboratory findings, do you say do a problem list as well? Did I missed that one?
Yes, please give me a problem list.
So my problem list, it's quite extensive. A 2-week history of weight loss, hyporexia, intermittent vomiting. The cat is quiet as well. I'd consider that on my problem list. Bilateral renomegaly, mild dehydration, mild anemia, unsure if regenerative or pre-regenerative, moderate to marked azotemia with hyperphosphatemia, hyperkalemia, hypocalcemia, and inadequate concentrating USG. Further interpret the laboratory findings. So there is a moderate to marked azotemia with inappropriately concentrating urine and a hypocalcemia as well, which could be related to the renal disease that we're suspicious this cat has. Further diagnostic tests that I'd like to do on this cat, I would like to do a UPC, even though the dipstick is normal with quite dilute urine. We may have proteinuria that hasn't been picked up. I would like to perform a urine culture as well via cystocentesis, just to make sure there's not a urinary tract infection there. I would also like to perform a thorough abdominal ultrasound with particular interest to the renal, parenchyma, ureters, and bladder, but I'd like to look at everything. Probably my starting point, what I'd like to do for this cat.
Excellent.
I'd also like to do an FELV and FIV on this cat, actually, as well, assuming it hasn't been done. But let's
love that. Well done. I don't know why it wants to go backwards so much. Okay. Excellent. So, an ultrasound was performed. The ultrasound report's here. I'll let you have a read through that.
All right.
When you're ready,
Yeah.
provide a prioritized differential list for what might be causing this patient's acute renal failure.
So that's in this patient, not just in non-specific, like, yeah. So on top of my list would be almost an acute on chronic phenomenon in this cat. So renal lymphoma would be my number one differential with acute on chronic phenomenon. Other things could be a pyelonephritis as well, would be something I would consider in this cat as well. Would be on the differentials. Bilateral ureter obstruction could be on this list, but I wouldn't expect the changes with the jejunal lymph nodes to be on there as well. But that would be definitely something on my list. They're sort of my top three. Do you want more?
I'm really bad at this game. Can you say that to an examiner?
No, not really. Well, they might.
Do you want more?
Is there any? Well, they'd be like, is there anything else? Right? Is there anything else? So
maybe FIP, Mitch.
yeah.
Good. Okay, moving along. Sorry, I'm just making some notes. Okay, so renal FNA was performed, and I've put the laboratory results back up here just for your reference. The FNA results were consistent with renal lymphoma. Describe your management plan for this patient.
Well, the first thing is this patient is sick. So before I do anything to try and treat the renal lymphoma, I actually want to treat the patient that's in front of me. So there's been some decreased appetite and vomiting. So I would want to start this patient on some intravenous fluids, and LRS lactated ringer solution would be my fluid plan of choice. I'd also start meropitant as well, and consider ondansetron and mirtazapine as well for this patient. I think it's feeling pretty unwell. Have we done blood pressures on this patient, Anna? Do we assume with, minimum database that they do blood pressures or not? Then I'd do that as well. Like, I don't know.
Yeah, great.
Blood pressures haven't been done on this patient. I'd like to do blood pressures as well.
Excellent.
For two reasons. This will help me direct my fluid therapy, but also my treatment plan and monitor my patient. I'd like to monitor my patient's ins and outs with the fluid plan as well, and make sure that I'm not causing fluid overload. After I've done all that and I guess stabilized my patient and made it feel much better, I would then consider treating the renal lymphoma. Something I'd use would be a CHOP protocol. So with cyclophosphamide, doxorubicin, vincristine, and prednisolone. But I'd consult a medical oncologist for the ideal plan for this patient. Other things that I would consider, this patient's got hyperkalemia. So going back to my initial treatment, I just want to put an ECG on, make sure there's no changes there. If there was, I could consider calcium gluconate, but it doesn't seem indicated in this patient, but just something in the back of my mind. Management plan ongoing. So once I've commenced the CHOP protocol, I would perform serial CBC and biochemistries as directed by the medical oncologist to monitor changes, whether I need to tinker with doses and those sort of things.
All right, I'm going to move on to the next question. So that's the end of that question. You did really well in that. The two spots that I was like, oh, could have put this on the list was further diagnostic tests to be performed. I would have ideally had BP on my list for that. But then because you mentioned it later, you got the tick for that. So yeah, you actually kind of addressed that already. And then did you actually say lympho in your differential list?
Yeah, it has my top differential, acute on chronic phenomenon, most likely to renal lymphoma.
Great. Yes, I heard the acute on chronic, and then it kind of dropped out a little bit, and I was like, I'm pretty sure he said that. Well done. Good. And I guess the only thing you still got marks for it because you addressed it later on, but addressing the hyperkalemia and the idea that like getting rid of the lymphocytes in the kidneys or reducing the number of lymphocytes in the kidneys is what's going to get the kidneys functioning and to get the cat eating again.
Yeah.
So there's kind of this urgency to get them on something that's anti-lymphocytic. So I probably would have started prednisolone while I was waiting for input from a medical cardiologist, oncologist.
So in this instance, would you give dexamethasone IV over oral prednisolone given the cat's unwell, or do you think they're both acceptable answers in this instance?
I think they're both completely fine. Yeah, I probably would have gone oral pred just because dex scares me a little bit in cats, but that's because I'm genetic. Yeah.
Yeah, for sure.
But yeah, you did really well in that. That was easy, very comfortable pass.
Cool. Thank you for that.
No worries. All right, Cheryl, your turn. I'm just thinking so Helen can't do the next one. What time are we? Yeah. Okay. Cheryl, you're up.
Okay.
All right. I'll let you read through there.
Okay.
Excellent. All right. Provide me with a problem list for this patient, please.
Okay, I wish I had a longer problem list, but so this patient has problem list would be chronic non-productive coughing that has been ongoing for 6 weeks, and mild wheezes that we can auscultate on ultrasound.
Excellent. Typical cat.
Mm.
So question 3A, describe the radiographic findings shown here. There are 3 radiographs, 2 laterals, and a DV. Please let me know when you'd like to flick through, and you can go back and forth as much as you'd like.
Yep, sounds good.
Oopsies. Sorry.
Could I go to the next one, please?
Of course. I should say that's the left lateral.
Yep. And then do we have a DV?
We do.
Yep, awesome. Okay, I think I'll be okay.
Oh,
Go to
okay.
the lateral and I'll start describing. So available for review are 3 radiographic images of the thorax of the cat. We have a well-inflated lung in all images. We have obvious bronchial pattern. So I can see my donuts and tram lines. There is a generalized bronchial pattern throughout the thorax. The heart is of a normal size. There is no pericardial fluid or no pleural effusion, sorry. Yeah.
Excellent.
And no obvious masses in the thorax. And the vertebrae are all normal.
Okay, now I've put the historical findings there, and then the radiographic report from a radiologist, which shows a lobar sign affecting the right middle lung lobe with mild bronchial pattern. So based on this additional information, construct an updated problem list or add to your problem list.
Yeah.
And then give me a differential diagnosis, provide your differential diagnoses based on the information provided.
I guess my updated problem list would be a consolidation of my right lung lobe, potentially.
Good. you can ask to go back and look at the radiographs again if you wanted to clarify anything.
Yes, please. Yeah, okay. So I guess my revised problem list would be feline asthma. Oh wait, sorry, no, ignore me. Provide your differential diagnosis. So differential diagnosis would be feline asthma, feline lungworm, potentially aspiration pneumonia. It's chronic bronchitis, less likely in the cat, but that's also possible. After coughing for 6 weeks. Eosinophilic bronchopneumonia, bacterial pneumonia. Yeah. Oh.
Excellent. Sorry. The client declines further diagnostics. List your your first and second choices of antibiotic therapy without further diagnostics.
I would use doxycycline, and amoxiclav, or maybe, I was gonna go for enrofloxacin. No, ignore me. That's not in cats. Sorry. Maybe amoxiclav.
And if the client did consent to further diagnostics,
Yeah.
list the further testing that you would like to perform in this patient.
So I would first do an SpO2. I know it's stable, just making sure it's breathing okay and oxygenating well. I would do a fecal float and a Bayman test to rule out lungworm, but it can be intermittent shedding, so you're not entirely ruling it out, but makes it less likely. I would do a bronchoalveolar lavage with a bronchoscopy. It might be a bit tricky in a small cat, but I'll do a bronchoalveolar lavage and perform fluid analysis and culture. That will also indicate what types of cells that's living in the lungs, and makes our diagnosis a bit more likely once we get that. And the culture to investigate for secondary bacterial infection.
Are you happy to move to the next slide?
Yeah.
Next section of the question.
Yes.
The general practitioner had trialed a 10-day course of amoxicillin clavulanate, but follow-up radiographs showed no improvement. A BAL was performed with the following cytological picture. Describe this cytology.
Okay, so there is a marked amount of eosinophils that can be characterized by their red granules, and a couple of macrophages, so the largest cells with vacuoles. There is also moderate amount of neutrophils. They do not look degenerate to me, so non-degenerate neutrophils, and no obvious bacteria.
Very good. Oops. What features on, hang on. There should be another question in there. Based on this cytology, what is your leading differential in this patient?
So eosinophilic bronchopneumonia or feline asthma, which is an allergic reaction in a cat, so type 1 hypersensitivity.
And what features on cytology would support a diagnosis of chronic bronchitis?
So with chronic bronchitis, we would see macrophages and neutrophils that non-degenerate, and cytological. The lack of bacteria and did I say non-degenerate neutrophils? Yes, I did. And
We'll move on to the next part.
yeah.
Why might a lobar sign persist in a cat with inflammatory airway disease?
I guess your lobar sign is forms when there's increased cellular infiltrate in the lining of your bronchial walls, and that can happen with chronicity, where you have all your inflammatory cells lining up on your bronchial walls.
Okay, end of question 3. I don't know what to do. That's cool. Okay, so you did really well. And
I
definitely
didn't feel like that went
I
really
know
well.
it feels awful, and like I was
Oh.
like, you've got everything on my list, but you're still like wanting to say stuff, so I don't want
I
to say
know.
to you,
I was
"Stop."
like, oh god, it's probably a fail.
No, not at all. So definitely, like, if you're kind of say, I might just take a minute to make sure I've covered everything, and yep, that's everything I want to go through.
Okay.
And then the examiner won't kind of sit there going, because then it makes you feel like you're missing something, but it's
Yeah.
actually that you're still, I just don't want to cut you off if you do have something that maybe I don't have on my list. So feedback wise, you got all the differentials. You did really well on that. First 2 choices of antibiotic therapy were exactly what I would have chosen, but I would have accepted others as well. I think I was more testing kind of antimicrobial stewardship in that, and penetration into the bronchial space. So both doxycycline and amoxiclav were the best choices, really. So then your investigation was excellent. The only other thing I had on my list was a CT scan. And it's not, I mean, that's because I've worked in specialist centers, really. But when I see a lobar sign, I'm like, something's going on in that lobe that like is different to the process that we've got more diffusely throughout the lungs. And the reason why I asked the very last question, what might cause a lobar sign, is typically it's actually obstruction of a bronchus in airway disease. So that, and that's usually just either pus or mucus or bronchoconstriction, which has resulted in like complete plugging of a bronchus, and we've essentially lost aeration of that lung lobe. And one of the differentials for that is aspiration pneumonia, as you mentioned. And it might be like a chunk of food or something like that just sitting in the bronchus that we're probably not going to clear that. And sometimes those patients do need to have the lung lobe taken out to stop the inflammatory kind of cycle in there, because that inflammatory cycle triggers asthma. So we've had patients that have just kind of developed this chronic bronchitis in one lobe because of bronchial obstruction that then turned into a chronic bronchopneumonia, which isn't really antibiotic responsive because it just can't go anywhere. It's just sitting in there stewing. So that was the kind of only extra context was the CT, just to really examine that airway and why that one lung lobe is behaving differently from the rest of the lungs. But you got it in your differential list. So they were the only 2 kind of feedback points, I think.
Could you point out the lobar sign, please, on the radiographs? I did not see that at all.
So
okay, now I see it with your mouse.
Cats are so subtle. So the right lobe is this
Yeah.
kind of triangle, and because the heart, it comes off the cardiac silhouette, so it's actually much harder to recognize in dogs than in cats. I find in cats than in dogs. I find.
Yeah.
But there's a line there, and there's a faint line here. that kind of makes up that right middle lung lobe, whereas in dogs, it almost goes out like a triangle. It's a little bit of a different shape. And then it's most easily seen on a left lateral radiograph, but it's sitting right. So this is the cardiac silhouette, this rounded bit,
Yeah.
and this is the lobar sign.
Okay, I see.
Yeah.
How do you know
But
it's the
you're right.
and not the left? I'm really bad with X-rays, but I'll get better.
Oh, I thought you did really well with the X-rays. Why is the right, not the left? So when you've got a patient lying on their right-hand side,
Yeah.
their left lung is more full of air than their right lung because the right lung's got more weight on it, so it pushes the air out.
Yeah.
So the more air you get surrounding an abnormality, the more it stands out. So this, you will see a tumor on the left-hand side of the chest more easily when it's surrounded by air. So you'll see it more easily in a right lateral. And if you've got doing a left lateral, you're more likely to pick up right-sided pathology.
Okay.
That makes sense?
Yeah, that's very helpful. Yeah.
Cool. All right. Now, next question. Mitch, do you need to go?
That I just got off the phone, so I don't need to do it anymore.
Oh, amazing.
It's fun. This is fun. So
it's fun, did you say?
Yeah.
You weirdo.
Yeah.
I like the oral exam. I reckon it's going to be fun. I like to talk.
Mitch also speaks underwater. Like he's so good at talking. So
I agree. You did so well, Mitch. You articulated it so clearly.
Yeah, you did. You did really well. And I reckon you'll scream through this. Like, I reckon you'll finish really early. Don't be alarmed. Like, you're very succinct in making your point.
Yeah, I know. I spoke to my mentor about that. She's like, it'll be fine if you finish a bit early. So
Yeah. Don't worry about it. Okay, so I quizzed Helen on a similar topic last tutorial, so I'm actually gonna skip Helen on this one and give Helen question 5. What time are we? Oh, okay, yes, you're gonna be quick, Mitch.
I
Okay,
will. Yeah.
question 4, read away.
Right. 4A, my leading differential diagnosis in this patient is immune-mediated hemolytic anemia would be on the top of my list.
Excellent. Should be an R there. I should have said make a problem list, but it's there. Like, I've only put the relevant clinical findings in there. So this patient has had a full hematology, full biochemistry, and electrolytes, as well as the urinalysis. And the abnormalities are presented there. All right, moving to next slide. Is any further testing required to confirm your leading differential diagnosis?
There are further tests. Yeah, there's further tests I'd like to do because I'd want to distinguish is this a primary or a secondary IMHA. I've got a lot of criteria there for the internal medicine consensus statement with spherocytes, evidence of hemolysis, but for me to distinguish between primary or secondary or primary and associative, depending on the language, I'd like to do further testing, such as infectious disease testing. So looking for Ehrlichia. I'd also like to do a heartworm antigen snap test as well. And I could do further imaging, such as an abdominal ultrasound and chest x-rays to eliminate other causes or associative causes of IMHA. Although the literature, I actually watched a webinar. I know this isn't the exam style, but I watched a few stuff with Luke Johnson, who said that it's like 40% of the time you find something, it's actually quite low. So I found that really interesting. So I know that's not exam style, but I just found that interesting. Yeah, there's further testing I would do. Which of those things? Oh.
Sorry. So you've already answered 4C.
And then, so for 4D, can we just go back to how the patient presented? And
Yes, of course. And that will be, sorry, I got lazy. That will be in
Yeah,
the
that's
slides.
okay.
So you have it.
Yeah, cool. All right, thank you. So, I would say that this patient is showing evidence of being hemodynamically unstable. So I would transfuse this patient. I would use packed red blood cells ideally would be my major treatment of choice after doing a major and a minor cross match. If that wasn't available, I would use whole red blood alternatively, but I think packed red blood cells would be better in this patient. I would use and immunosuppressants as well, so either prednisolone or dexamethasone, an antithrombotic agent, so clopidogrel or rivaroxaban as well would be some choices I'd be considering. I'd use clopidogrel. That's just what I'm comfortable with, but I would use clopidogrel. I would then recheck this patient's PCV-TP post blood transfusion and then continue serial monitoring of this for at least 24 hours in hospital. And if the patient was stable and coping hemodynamically, I would discharge this patient and then perform serial packed cell volume and total proteins every 24 hours until there was, and blood smears until there was no evidence of any hemolysis or spherocytosis. If that was continuing to day 7, I would then consider adding in a second line immunosuppressant such as azathioprine or cyclosporin.
Okay, 4 marks. Except that you answered the question before before I asked it. So
with this question, sorry, Anna, it sort of fits the criteria through that IMHA consensus statement. So is that what that question's asking, or?
This, yeah, is any further testing required to confirm the diagnosis? So you said that, like, I've got evidence of hemolysis, evidence of immune-mediated destruction, and anemia, a regenerative anemia. So you've ticked all the boxes required to make a diagnosis. So I was really testing that, and I guess the only additional test you could have added on was a Coombs test, but in the present,
I had that written down, I just didn't say it.
Yeah, well, and actually, it's nice to hear as an examiner, but I can't really put it on the, like, having asked that question specifically, I can't expect you to say Coombs test because you don't need it with a positive agglutination test.
Yeah.
So you ticked all the boxes there.
Thank you.
Okay. Oh, Helen, sorry. This one was like a 4:30 a.m. one. I was like, I'm gonna make this hard. Okay, so this one's gonna challenge. This one would challenge me. So, if you nail it, I'll be insecure.
Let's give it a one. Okay. If cost constraints were a factor, the 2 tests I would prioritize would be an ECG and a minimum database with electrolytes and glucose. The reason I'd justify those would be number one, probably the most concerning thing is the bradyarrhythmia on physical exam, which could explain the episodes of collapse. And an ECG is non-invasive, non-painful for the patient, and relatively low cost. Of course, we need to pay for the equipment at the clinic, but it's relatively low cost to the clinic if cost constraints are a factor. And secondly, the minimum database, again, low cost, but obtaining whether there's electrolyte abnormalities or hypoglycemia that could be life-threatening is a quick, non-invasive, cost-effective way to rule those out.
Moving on to part 2 of this question. Electrolytes, biochemistry, and hematology are within normal limits. An ECG was obtained. Describe these ECG findings.
Okay. So the QRS complexes are tall and narrow and normal in appearance. And there is a P wave that precedes every QRS complex. So the QRS complexes look quite normal, indicating normal ventricular depolarization. There is more than one P wave present for every QRS. So there are P waves that stand alone and do not and are not followed by a QRS complex. In places, it looks the RR interval looks regular. Although she had an irregular rhythm on physical exam, didn't she? Yeah, the RR interval looks regular.
Irregular, yeah.
In this ECG.
Mm-hmm.
And there is a 3-to-1 ratio of P waves to QRS. So there are 2 P waves that do not result in a QRS, followed by a P wave that results in a QRS normally. It's consistent with AV block. I should say it's consistent with second degree AV block. And within that, it's consistent with is it high grade if there's 2, or is it more than 2? I think it's high grade because they're not getting progressively. There's no progressive elongation of the PR interval. It's just block. So I'm going to say it's high grade second degree AV block. And yes, that could be the cause of the collapse episodes.
Excellent. If the ECG trace had been this one, would you have been as comfortable to say it was the likely cause of collapse?
So in this one, the T waves are abnormal, so they're sort of tall and tented, which can be concerning for an underlying abnormality or metabolic abnormality like hyperkalemia. This rate is irregular, but it looks irregularly irregular. And the QRS height alters between beats, although not regularly, so not quite electrical alternans, because the dog could collapse with that finding if it's got a pericardial effusion, but it's not regularly, so that might be an artifact on the ECG. And the degree of block is, there are 2 episodes of AV block, but with only 1 P wave that's not conducted. Given that there's the AV blocks are for shorter periods, I would say it's less likely to be the cause of collapse. Not exam setting, but I actually don't know.
You did really well. I can't believe you did that well in that question. So you assessed that ECG, the first ECG, perfectly, called it a high-grade AV block, so Mobitz type 2. Is that right? Yes.
Yeah.
And Mobitz type 2 is the one that we get concerned about. So that's where we don't have any like progressive elongation of the P to R interval before we drop a beat.
Yeah.
Whereas this one's actually, so the QRS morphology is abnormal, T morphology is a little bit abnormal, but it's actually not kind of the point of the trace, which like should have got a better trace, but Google can only deliver so much.
Yeah, that makes sense.
So we've got P wave, slightly longer, slightly longer, slightly longer, slightly longer, missed one. And here as well. So PR sort of short there, slightly longer, missed one.
Yeah.
This is a type 1 block,
Yeah.
which is generally not associated with any clinical signs of pathology, as
That
opposed
makes sense.
to the first one, which was a type 2. Now, you didn't say specifically in this one, I can see the PR interval progressively getting longer before we skip a beat, but you did say in your assessment of the other one, I can see that the PR interval is not changing before we skip beats, and therefore it's a high grade. So actually you've already got those marks, which is what I was trying to tease out here.
Sure, that makes sense.
So yeah, you're exactly like you're prioritizing testing was absolutely spot on. They're exactly the tests that I do. So anemia was the only thing you didn't kind of mention.
Of course, yeah.
But also what dogs are bradycardic with anemia. Like didn't really make sense.
That's a good point.
But all hypoxic injury to the heart for whatever other reason.
Mm-hmm.
But yeah, that's end of exam. Ready to go, party time.
Cool. Right on time.
Hey?
Right on time.
Right on time. Yeah, that's unheard of.
I do.
We usually get through like 3 questions. Excellent. Okay. So you guys are all very well prepared. And the only things is going to be exam technique. So take a leaf out of Mitch's book, put a full stop at the end of your, like you can say, I'm just going to take a minute to make sure I've covered everything, and then full stop, rather than looking to the examiner to tell you that you've got everything on the list, because they won't be able to do that. And that's going to set you off.
Thank you, Anna. That's really helpful.
Thank you.
Yes, I think it was a good idea to do a proper structure one. I was going to just throw questions at you, but I think it's good to take away some of the surprise in the exam setting. Good luck, all of you.
Thank you so much.
No worries. I'll see you on the flip side.
On the right side.
Yeah.